One of the new ones.
All right, we're gonna try an audio check here. Could you guys, somebody online, just tell us if you can hear us okay?
We can hear you.
Okay, awesome. Thanks, Ben. I'm gonna just try one thing real quick here. Hey, Ben, could we try one more time? Could you tell us if you can hear us?
Yeah, I can hear you loud and clear.
That didn't work. All right, we'll just play for my MacBook then. All right, welcome everybody to Run Review July. We just had Run Review last week, so this feels like a little bit of a whirlwind up in Sky Valley, but thank you all for joining. And we will go ahead and get started here. So kind of roadmap for today. I'm just going to go through a quick rundown on the KPIs, which is kind of a Snohomish County EMS kind of thing that just different kind of metrics that are kind of monitored, and I look through each month, and because the three agencies that I work with you all are relatively small volume, it doesn't necessarily make sense to go through each of these at Run Review every month, but I was going to give you guys kind of a mid-year update on what those look like. I pulled a couple of papers for this month. I'm hopeful this is interesting to you guys, so I emailed them to you. Did you guys get them in your Granite Falls? Okay, so I don't expect you I just sent them this morning, so don't worry about if you're familiar with it or not, but I just sent it to you so you can look at it later. These are two pretty big trials that have come out in the last 6 months, basically 7 months, in emergency medicine and EMS that are will help kind of guide our practice moving forward, I think. And I think there's a lot of relevance, and hopefully we can generate some good discussion from it. So we'll talk about those in addition to our runs from this month. As always, just keep anything we talk about from Run Review private, including patient care, how our colleagues manage patients, any PHI, all this should be confidential, and this should be a safe place for kind of learning and discussion. And please chime in with all these cases, and even if it's not your case, it's helpful to kind of get different perspectives on things. So let's jump into it here. Okay, so KPIs. Basically, if you don't know, these are there's three major ones that we are looking at from a county perspective this year. One of them is end-tidal CO2 use following intubation, just to confirm tube placement and for monitoring post-intubation. The other one is oxygen administration in patients who are hypoxic, which sounds like a very obvious thing, like giving oxygen to people who are hypoxic is just what we do. This is more of an issue of documentation, as I'm sure you're aware, than actual practice, and we'll talk about what that looks like because it's kind of goofy. And then the other one is getting ECGs in patients who have syncope, or any honestly discussion of syncope in the narrative is what I found, or including it in the differential. So it's just something I think that's probably the biggest one that we could say maybe there's some improvement in practice that we can glean from looking at some of this data. And I'll get some of this, my more specific feedback out to you guys over the course of the next week in ESO and to the leaders of your departments. So end-tidal CO2 use, you guys are awesome with. It's honestly 100% usage. Granite Falls and Sultan, you hit this pretty much every time. I think there was one case where I think was maybe a documentation issue in one situation, but it was not a patient care.
Documented as a miss on the inline end-tidal, even though you can see 45 minutes of end-tidal measurements. We're trying to figure out what happened with that one.
Yeah, I was actually so one thing I was gonna ask you guys is sometimes there's documentation for both digital CO2 and waveform end-tidal CO2 for KPIs.
That's what happened.
Yeah, so the way the KPI is written is for waveform end-tidal. When digital CO2 gets put in the chart, what is that? Is it, because I'm assuming you're just using an Entitle on the tube and it's attached to the life pack, correct?
That's basically what it is, but I guess it needs something different. My dream is, and they're trying to get more people to be on ESO committee, if anyone's open to it, to switch so that either digital and waveform are both counted for this KPI, or better yet, if there is an in-title reading post-innovation, then that's just counted.
Okay.
So we're trying to wrangle with that and see if that's something ESO will allow.
So in other words, if it's like listed in the vitals, then that just counts.
I think that would be,
Yeah.
I think that would be
Makes sense.
efficient, and anything's easier to change in human behavior, right?
Yeah.
Anything.
Yeah.
So,
Right. Yeah. Does anybody from the Sultan side have an idea of where this digital CO2 like kind of input from ESO is coming from? Is that measured differently or different input from your guys' perspective? Okay. Okay. When you do endotracheal intubation, though, you can select like how you confirmed your tube. Is that right?
That's something else.
Yeah.
Sorry to interrupt. Dr. K always said do video laryngoscopy instead of endotracheal intubation. Sounds like we're swapping back to endotracheal intubation for documentation purposes, or
Oh, I haven't actually heard that part, so
Okay.
maybe, yeah.
Whatever the guidance on that may be.
Okay. In any case, I don't see it. I mean, my concern is whether there's patient care issues here or there's not. So keep doing. This is the nice thing is that this is like clearly standard of care now, whereas maybe definitely 10 years, but maybe even 5 years ago, this was not standard of care. So it's a nice change. I mean, for those of you who've been around for a while, I'm sure that's true, right? It's been a big change over the last few years. So that's a for sure positive. Okay. Okay. Oxygen for hypoxic patients. If you just look at the face value, this is like comically bad. Like I looked at the countywide and it's like 53% compliance for this. And we're like anywhere from 40 to 60%. And looking through all these charts, this is basically issues where we'll have a chart that's, a patient has one pulse ox reading of 88%. And the rest of them are normal. And then this is documented as a hypoxic patient that we didn't treat with oxygen. And so, yeah, I'm open to thoughts on what to do about that. I don't really, feel super strongly.
Well, so the file signs that it says, pools of patients SpO2, and you put it in, it says on oxygen or off oxygen. Room air versus O2.
Yeah.
So I was just thinking about this the other day when I was doing a couple reports. It's like I started putting in oxygen, like when I would put it on the patient.
Yeah.
I've never did that before. It just recently changed. I was like, I just put O2, giving the patient O2 at a certain point at a certain time.
Yeah.
I never did that for the last two and a half years. Out of those, the SpO2, it would be a reading, and I would click on oxygen. That's how many liters.
Yeah.
So there's two ways to do it, I guess.
And when you do that, it says like 93 ox on the readout, correct? I'm pretty sure it does. Yeah, on the ESO report. So that's the kind of nice. Adam's just talking about like when you actually put a patient on oxygen, on the ESO report, it actually reads out what their SpO2 reading is, and it'll say ox, which is yeah.
But then on the flow chart, I've been putting when I apply oxygen, and now I'm giving the patient oxygen.
Yeah.
So it's like kind of do two things. I'm doing it's redundant kind of, but
yeah.
It's doing it.
I think it's actually helpful. I mean, it helps. I mean, if ever there is a question about when the oxygen was applied, it makes it much easier to read. You're like, oh, this is where the oxygen was applied. This is how the patient responded to it. So I think that is nice. And then I would say if you have one reading that's way out of line from the rest of them, I think cleaning that up in your ESO before you submit your report is probably the biggest takeaway here. I mean, the ones that are most noticeable are like, patient has oxygen sats of 98% and there's one of like 20%, and then the rest are and then the rest are normal. Yeah. Yeah. And what I've actually noticed too is that where you'll run into this issue the most is patients with arrhythmias. So like your atrial fibrillation or somebody with just a funky paced rhythm or something like that. I think you'll be more likely to just get weird pulse ox readings. And so just be conscientious of those reports, and so that it doesn't, in retrospect, just look like a really funky case where you just ignored hypoxia for a long period of time. And the other part of it is just, if somebody is hovering lower, just, it is best practice to just put them on some nasal cannula. If they are hypoxic, it is important that we treat it. So I don't want to downplay that part of it as well. So if a patient is hovering in the lower zone in the pre-hospital setting, just put a little bit of oxygen on them, and then get a little bit more data. And it may be the case they don't need it forever, but I think that would be the takeaway for that. The other kind of weird one is like, if you get an asthmatic patient and maybe a BLS unit starts them on like an albuterol neb or something, and then they have an initial hypoxic reading and they get a neb, and then they clear that, then they actually end up, it doesn't always register as having oxygen administered to them for that encounter. So that's another one to maybe we can think about how to address that, but you may just think about putting kind of oxygen in your flow chart for that too, if you're getting a neb to somebody who was hypoxic at one point. Okay. KPI. So the last one is ECGs for patients with syncope. This one is pretty variable as well, and I think that stems from how we use syncope in our kind of language and differential diagnosis. So a lot of times we'll throw it out. Somebody has an event where they feel dizzy or near syncopal, and we'll throw out a differential that'll include syncope oftentimes, even though that maybe a true syncopal event is lower on our differential. And so those get lumped in with this kind of KPI. But this is probably a good one. If somebody's dizzy, lightheaded, they lose consciousness, an EKG is a really critical kind of like just initial evaluation, because you just want to take any kind of cardiac arrhythmia or primary cardiac process off the table. So especially for BLS folks, if this is part of what you're considering, don't be afraid to call and ask for ALS crew evaluation or 12 lead if appropriate. And then just know that this is kind of going to be part of, when you're including this in your discussion, is syncope, that this is going to be kind of the expectation is that we get a 12 lead. I mean, the 4 lead EKGs don't count for this one. Any thoughts or? Yeah. This is the one we're looking through. I probably saw a handful of cases that maybe have the most like intervenable, like probably should have got an EKG on this patient or that patient. So I'll keep an eye on this and give a little bit more direct feedback over the next couple of months on this one. All right. Okay. We're gonna. There's two papers, and I'm split them up because I don't want people to get too cross-eyed on me. I'm just talking about research papers. The first one, we'll go through a little bit quicker. So this is the SWIFT trial. And has anybody heard about this trial, or anybody aware of it? Okay, just read it. Okay. And folks online, we have a small group in Granite, so please chime in as if you're in the room here, because it's just the 3 of us and 4 of us in here. So, yeah. So basically, this is a randomized control trial in New England Journal, and basically this is looking at transfusion of whole blood products versus component blood products in the pre-hospital setting for trauma patients. So, good sized pre-hospital study, which is good for us because it's directly relevant to what we do, which is an important kind of feature when we're looking at any kind of research, as whether it applies to your practice. So let's go through it a little bit. So the question is whole blood transfusion in the pre-hospital setting superior to standard of care, which is basically balanced transfusion of PRBCs and plasma for the pre-hospital setting. This was conducted throughout the UK. There's 10 different air ambulance, air medical transport teams that were a part of this study. And basically the inclusion criteria was trauma patients that were deemed to have life-threatening bleeding were included in the study. The transport teams were physician, paramedic teams, and the standard of care for this particular setting, like I was saying, is balanced transfusion of PRBCs and plasma. So a little bit of background on transfusion and trauma. So in the 50s and 60s, plasma and whole blood transfusion programs were started as part of the standard of care. There was a long period of time when we kind of switched to early crystalloid-based resuscitation of patients, basically the 70s through the 90s, which seems kind of wild to think about now, just that trauma patients just coming into the trauma bay and getting huge boluses of crystalloid, which we've really moved away from. In the 2000s, this started to change. So in 2007, a landmark paper came out that suggested that a balanced resuscitation using kind of equal parts PRBCs, plasma, and platelets was superior to other methods of resuscitation for trauma. And a lot of this data came out of the Afghanistan and Iraq wars, and data and experience, I guess I would say, for a lot of the sick trauma patients that we had over there. In addition to transfusion data, there was the big CRASH-2 trial in 2010 came out, which showed reduced mortality when TXA was given early, and especially the pre-hospital setting, in trauma patients that have significant hemorrhage. That was another big change. In the 2010s, we started moving toward whole blood transfusion again. Has anybody heard of the walk-in blood banks that they use in the military soldiers? Yeah. So basically, these soldiers will be part of a squad who are donors. They're like O positive or O negative blood type, and they will give basically auto transfusions to fellow soldiers, like right there in the field. So,
Surprised that it's pretty basic,
right.
Fighting.
Yeah. So there's and with that is obviously you're talking about whole blood product transfusion. It's not being processed in any way. But with that comes some data suggesting that this whole blood transfusion is actually, there's some benefit to it. Potentially some limitations for whole blood. So from a medical system standpoint, you have to think about a lot of things like, how do we store the blood? How is it going to be distributed amongst the communities? There's shorter, if you just talk about a unit of whole blood, the shelf life is 21 to 35 days. If you break the blood into components, you can make the different components oftentimes last longer than that. And that's oftentimes why hospitals will use components. If you also think about how hospitals use blood, you could think of, like, for example, a chronic kidney disease patient who has chronic anemia. They are only missing their red blood cells, and they don't need a full blood transfusion of platelets and plasma and things like that. And actually, a lot of the issues we have with kind of adverse reactions to transfusions are due to volume overload. So it actually is better to give components in some cases to patients. Another example would be a patient who's on chemo for cancer, may have very low platelets or ITP, and you may just want to give them the platelets and not any other blood products. So there's reasons for just giving components. But for whole blood, when we're talking about trauma, we're talking about patients that are losing kind of all the components at the same time. So back to this study. So this was a total of 942 patients were randomized, 616 were included, which is a big study group size for this sort of study. They put 314 patients in the whole blood group and 302 in the standard care group. Patients were excluded if they had, cardiac arrest or they couldn't consent. And so the primary outcome was death from any cause at 30 days after and or massive transfusion. And then the secondary outcomes are kind of as listed below, things you would kind of care about after a patient had a major trauma and their kind of hospital course afterwards. So this is the basic outcome. So the comparing the whole blood group to the standard care group, essentially there's no significant difference between the two study groups. So the major takeaway from this study is that there wasn't the big difference that they thought. So some things to think about for this study. So the only major difference between the groups, and this is more of the secondary outcome, is that the patients in the whole blood group had a slightly higher PTT. And this is probably because the coagulation factors kind of break down over time. So it really the timing of how long the whole blood's been since the donation matters in terms of that, but it didn't seem to kind of correspond to any patient-related outcomes that made a big difference. The other kind of thought is that, this is only 2 units of blood transfusion, and it's just the pre-hospital setting. So it may be that this dose isn't big enough to show the benefit of whole blood. So they were only giving up to 2 units of blood in the pre-hospital setting. If you're talking about moving on to whole, massive transfusion, it is still quite possible that the giving whole blood may be better. But at least in terms of this study, it doesn't seem like whole blood was shown to be superior. Yes. Yep.
I was like, it has to be better than crystal, but yeah.
Yeah. Yeah, definitely. So yeah, they didn't even include that in this study. So how does this affect us? So we are looking to expand the availability of blood products in Snohomish County. Looking at the kind of heat map, I mean, I think it depends on where you're working. In urban areas, it's going to be more common, but even in kind of areas that are more rural, you're going to have a handful of cases each year where giving pre-hospital blood will make a difference for the patient. And so, we're working on what exactly that's going to look like, and whole blood is what we're hoping to still get. There's arguments for both, but one thing from, I think, your guys' perspective that is worth considering is that, if you talk about ease of transfusion, in the component transfusion, you have like 4 different bags of things to open up, do all the paperwork, transfuse, all that stuff is going to be, it's just going to be more work. And honestly, I think probably more risk of like error and just like difficulty with administration. So there probably is still an argument, I would say, for whole blood, but this is just kind of an interesting trial for us to think about, just because it's kind of directly related to what we do. So yeah, any thoughts, questions? I know it's maybe not the most exciting because it's kind of a negative study that doesn't show a major difference between the two, but it is kind of helpful to know why we do what we do and what the data is behind both of them. I think my bottom line that I take from this is just getting some sort of blood product to the patient is probably the most important thing. Yeah, agreed. So especially those calls on Mountain Loop Highway or Highway 2 is kind of the situations that come to mind where the air medical resources are really, that's going to be probably one of your biggest indications for making those calls early, and that delivery of that resources is going to be huge. Yeah, and I guess I didn't mention that part. So the cost is I think pretty remarkably different for whole blood, and that's a big barrier too. Do you have a question, Adam? Or
If this program gets up and running, do the agencies that are gonna give whole blood need like a major type of blood or type system, you know, like a they have an OR slide bag? Seen it before, but
Yeah.
yeah, do you need that to get that temperature?
Yeah, you should. I mean, Emmy might know more from I wasn't at the meeting yesterday, but I would say standard practices use some sort of rewarming device because it's going to be stored cold.
Yeah, so it's another cost, you know. It's instant.
Oh, sorry. Okay.
Yeah.
This goes in this machine.
So I'm not like.
No, nothing wrong with it.
So a Ranger or something to warm it up, and it has there's cost of that. The tubing is like, single use and expensive, but it kind of heats in coils in the tubing. So that's something as well. So, all right, but again, this is another for a lot of us, this is kind of a rare case, but something that we want to plan for. Okay, well, let's get into some cases here. Thanks for piping in. This first two, I think, are actually Adam. So I'm glad you're here, Adam. So this one is pretty recent. So this is a logging accident from last week. So yeah, tell us, I just have the initial narrative here, but tell me what this call is about here.
It wasn't a yarder, it was kind of like a bulldozer type deal.
Okay.
And the guy was underneath it, fiddling around with the hydraulic lines, like laying down right underneath where this thing was stuck, like this backhoe looking thing. And the hydraulic line snapped, sprayed everywhere. This thing crushed his upper chest for 2 minutes, apparently. The people on scene took some sort of chain and like a winch or something and got it off of him. Put him in the flatbed pickup truck and did a rendezvous with us like halfway up the mountain, which was awesome. So
10 out of 10.
yeah, this guy was awesome. He got him out of there and then started hauling like 100 miles an hour. He said he was going 90 miles an hour towards us. So the response time wasn't that bad, which is really good. Got on scene.
How did you choose a response or a rendezvous point?
I don't know. I just said, pickup truck's heading your way.
Oh, okay.
So I saw this
Yeah.
cops in front of us and they pulled over, opened the door. This guy was moaning. He was unconscious but conscious. Like he was just moaning, writhing around. He wouldn't track, wouldn't answer the questions. Just this howl of pain.
Sure.
He had some sort of a little tiny petechiae kind of around his face. He looked like his sternum was just bruised.
Yeah.
Right when I was kind of doing my initial assessment, I could feel subcutaneous emphysema. What I thought initially was just cracked ribs because it was just crunchy. But after thinking about it, it was a lot of subcutaneous emphysema. Got him back. Started going immediately. I gave him 2 milligrams of Versed right off the bat to kind of calm him down because I knew we were going to.
That's actually, sorry, I'll just stop. So it's an interesting kind of point of physical exam that Adam's talking about there is kind of palpating the chest wall for subcutaneous emphysema. And if it's something you have appreciated before, then you'll never forget it because it feels like kind of putting your hand over. Yeah. Over like bubble wrap or something like that. And so, and oftentimes, for the most part, rib fractures are not like that unstable. It's kind of, if you just light pressure with your fingers, you can kind of feel that under this. But it's an important physical exam maneuver as you're doing your chest survey. It can be really telling. So sorry to interrupt, but I think it's just a good point of kind of your exam for your trauma patient.
Yeah. So besides that, I think vitals, our initial set, I think were decent.
Yeah, I have more vitals here later, but we'll
Yeah.
get to that in a second. Yeah. So you did have it. So I guess I wasn't sure. You did have a blood pressure. You were able to get a blood pressure. Okay. Okay.
You know. He was flexing, like I couldn't even get an IV, anytime we put like a electrode on, it'd be off, you know, so I needed to calm him down a little bit, so. And I knew I was gonna intubate this guy, so, hold on, the medic unit, CERP showed up, we, did,
And what was tell us more about like the decision to intubate, but also his like his neuro exam, and you kind of talked about this posturing, and what was he responding to, and what wasn't he? Nothing. So he's just like moaning,
His arm will
nonsensical.
go, he flexed and extension and flexed, and anytime, you know, he was rolling around the gurney basically.
Okay. So yeah, that's an important. So sometimes, you know, when I read decorticate, I wasn't sure if we were talking about like
It was
kind of like stuff you see with a seizure or
tight.
okay.
Couldn't even make sense.
Okay.
Yeah. Literally use all the strength to straighten out his arm so I can get some access.
Okay.
I'll just hold it still so I can get access to before the 7 minutes.
Okay.
So, yeah, so in my decision to intubate was this guy was not, even after it was said, he was not there.
Yeah.
HBCS was forward.
Yeah.
So.
Yeah. Yeah, and because he didn't have he also didn't have any like head trauma.
Yeah.
I mean, you don't know that at the moment
Yeah,
probably
like-
because he's covered in grease too, so it's a little.
So there's no evidence of trauma in his head, it's all upper chest, sternum.
Okay.
I was thinking, you know, I was going down the list and, you know, he had a cardiac contusion, pneumothorax, I was, so the lung sounds were clear initially, so I was like, a clear and equal. So I was like, I was going on the right path, I don't see pneumothorax coming, you know.
Mhm.
And then, so we got there, we intubated him, we did the head injury protocol, we gave him a lot of fentanyl, because I still didn't know what was going on in his head.
Yeah.
So there you go, a lot of meds. Eat the tube was super easy, it was great view, we
Good.
tubed him very quickly. And then all the way to the hospital, I can't remember his vitals, I think they were all pretty.
I don't know why none of the blood pressures showed up on that. I might have not snipped the right section of the vitals, but you end up getting good blood pressure back, and the pulse was
Yeah.
better than that. So yeah, I think I might have missed a section of vitals here, so I think that's on me. But
Yeah, I should have cleaned that up, sorry, but this is a rough, it took me a long time to kind of write this.
yeah,
So,
This is a mess. Yeah, they're, not you.
yeah,
The call is a mess. It
Yeah.
sounds like you did great.
So, yeah, I mean, I was thinking there could have been some sort of brain injury as well on this because he was crushed, you know. And I didn't know if 2 minutes was accurate either. I was just assuming he had a brain injury.
So what's just to think, so you brought up I like your differential here. I'll open this up to the group. So you have a patient with significant chest trauma that's let's say just kind of unresponsive with no signs of head injury. What other thing, it's a little bit of a read my mind question, but what other things should be on our differential here of what could be going on to cause them to have kind of changed mentation? And I think may have actually happened in this case, but not a head injury.
Yeah, like he was breathing for, you know.
Okay.
He has an acute brain injury, like don't tip my tongue, but yeah, if he wasn't breathing for 2 minutes, I could see a little.
Hypoxic brain injury.
Yeah.
Yeah, so it could have affected his ventilation. Yeah.
If it was 2 minutes, it could have been 5 minutes, right? There's a big difference between you not breathing for 2 minutes and not breathing for 7, 8, 12 minutes.
So you brought up, but so that's a good point. You also wrote blunt cardiac injury here. So what's another? So remember Commodio Cordis, or remember the football player a couple of years ago that got hit in the chest and had a non-perfusing rhythm on the field? So I almost wonder if something like that happened, because this gentleman actually did end up having a sternal fracture, elevated troponins. He may have actually had a VFib or something like VTAC, something like that was not a perfusing rhythm, and maybe that's why we weren't seeing totally normal mentation in that kind of moment. So something to think about. I mean, I think you got everything on your differential here. It's just an interesting case of why did it present the way it did. It's just so just and a plug to as soon as you can get somebody on cardiac leads and monitor their rhythm with any blunt chest trauma like this.
So yeah, Nicole and great. I'm glad he walked out of his discharge. Yeah.
Yeah, so this gentleman stayed stable in the ED, trace right pneumo, contusions of the chest, again, blunt cardiac injury. He had a sternal fracture, was the most significant trauma, and some pneumomediastinum that just kind of improved over the next couple of days, and it was actually discharged 3 days later. So
Jeez, that's it was 50-50 this guy got died. Because I was thinking all the swelling, the edema,
Yeah.
around his chest and heart would
Yeah.
cause problems for it. But
Yeah.
right? He wasn't. I guess he wasn't crushed as much as I thought he was crushed.
Yeah.
Some aortic,
Right.
section.
Yeah, it's absolutely. Aortic injury is on the differential, and it shows you, I mean, how much a young, healthy patient can tolerate sometimes in terms of trauma is kind of surprising. So,
Yeah, great, fantastic.
so yeah, good case, good outcome. Any questions online or comments or? Yeah. Yeah, I think just a good case of like a really good trauma survey to start, just good covering the basics, airway management, ABCs, and then the little kind of lessons being the examining for crepitus, good, and then getting the tele leads on and looking at the rhythm if you're not sure if the patient's perfusing well, which I think this person sounds like he had bounding pulses for you. It doesn't sound like that was as much of a concern on your first exam, but just something to keep in the back of your mind for what could be going on with the blunt chest trauma. Okay. All right. And then your second case here, also a good one. So tell us about this one.
Francis, you want to take this away?
Oh, is this Francis's? Okay.
That was how we came to this adventure on.
Okay.
Oh, man.
It came by it honestly.
Wife saw him go down in the kitchen. She began CPR. Getchell got an eye gel in. They got 3 shocks on board immediately. Did good CPR.
Fantastic.
Adam showed up, did 4 more shocks.
Mhm.
And then when I showed up, we were getting ready for a DSD. We were getting set up from it, and then we got a radial pulse back.
That was after lidocaine boluses.
Exactly.
Amiodarone came later, but that was yeah.
So we got pulses back, so we abandoned the DSD plan and started focusing on transport. He died again, but we got him back in like 20 seconds. We dosed him immediately in 3 shots.
Then amiodarone was given after that.
Yeah, then amio was given, loaded him. He died a 3rd time in the rig. When we had the lupus, you got him back, I think, literally in under 8 seconds.
That was the VTAC, right?
Yeah, we're just like, quit.
Okay.
And then he did.
Yeah, there's like 15 pages of rhythm strips on this report, I think.
Blood pressure was only a little soft and it improved hugely with minor epi. And then for one of the weirdest days of my career, he began gagging on the eye gel. So we had to take it out.
Yeah.
And then I asked him if he was going to vomit and he said no and then apologized. We handed him off to Prob. Registration asked him for his birthday and he gave it to them. He gave them his birthday.
Yeah.
We had a hard time getting a clear 12 lead, but we were very confident it was a stiffy.
Yeah.
There was enough going on, and he responded so well to the antiarrhythmics. And
Yeah.
Okay. Well, that's the very quick version of this. This is a lot of good stuff to dive into there for what happened with this case. So You got that, so Gatchel got there first?
Yes.
Initial rhythm was shock advised, yeah. And so in a 56-year-old male, and initial rhythm being, VFib or VTAC, you certainly want to have a primary cardiac cause high on your
I
differential.
found VFib clearly.
Okay.
in my, after we got everything changed over, I was like, oh, there it is. Okay,
Yep.
got it. Yeah.
So this is the first EKG. I always include these because this is just the reality, right? You get your first one and you just have to do what you can do with it. So there's not a whole lot you can make of this. The computer interpretation thinks it could make something of it, but it's not even worth talking about. This is the second one, how about some folks who weren't involved in this call? What do you guys see on this EKG here? Somebody from Sultan. Or Ben.
You got inferior elevation. I don't see any significant depression. T waves are upright. You got kind of a prolonged QTC. Narrow complex sinus, Brady. Yeah, I mean, it looks like an inferior STEMI, which would make sense given he had a VFib arrest or a VTAC arrest, whatever it was.
Great. Yeah, the prolonged QTC is interesting too. You could definitely see this T wave just floating kind of over halfway between the RR intervals, just my eyeball of it being certainly prolonged and probably contributing to the going in and out of VTAC and VFib.
My doctor asked me, I hadn't done this.
Literally 48 hours
Yeah.
later. I was like,
Really good.
I thought about it. I lost 10 minutes to sleep off that one.
So this is the narrative of a pretty lively call. I think I have, okay, so these are all the interventions, which I thought was just interesting to go through. So initial crew gets there. They got an iGel in, some defibrillation.
Should have done prior to running the stuff, but.
That's okay. But the IO is from the Getchell team as well.
That's me.
Oh, that's you. Okay. Okay. So it's maybe the order's a little bit funky here, but anyway, a few rounds of defib, and then your antiarrhythmics. Probably what helps stabilize this patient, honestly, is just getting enough antiarrhythmic on board to hold them into a perfusing rhythm for you, in order for you to get them to the hospital. And that's, I think, probably one of the big learning points is this patient is having a STEMI. One of the things that can happen in a STEMI is that you could have ventricular arrhythmias, and that's what causes the cardiac arrest. And once you stabilize the ventricular arrhythmia, they're not like your other cardiac arrest patients that, like a PEA arrest, that just stay arrested. It's not a issue of heart squeeze generally, it's that the arrhythmia is not a perfusing one. So once you correct that, they probably, as this gentleman demonstrated, he didn't need to stay intubated. And actually the fact that you didn't have to positive pressure ventilate him after that probably helped save him. So if a patient is asking you to pull out the iGel or a tube even, and they're fully awake, it's hard to pull out an intratracheal tube, I guess, in an otherwise, patient that you have situated. But an iGel, I think this is just a good judgment call in the moment of what you do with what's in front of you. And because
We discussed it, we're like, don't normally take out tubes of the people. And
Yeah.
Yeah, he's like looking at me and tracking me, and I go, I asked him a question, and he's like, he was GCS 15.
yeah,
14.
reaching for it.
He was reaching for it. He wanted it. So it's like his time.
yeah. So it's an interesting, and admittedly, I just did one on my last shift, and it's something I rarely do, is I extubated somebody. But yeah, so criteria is you need somebody that's awake, that can follow commands, that clearly has a respiratory drive that can support the extubation. And I guess the biggest teaching point is every time I have an extubation, I'm already set up and ready for the intubation to happen right after that, because every once in a while this is going to go south, and it's going to happen right after you pull the tube out, right? So
And
So-
then we pulled it out and put suction in, and then pulled
Yep.
it out.
yeah, that's another good point. they'll have a ton of secretions, especially with an eye gel, getting that suction ready so they can clear their airway out. All those are huge. But again, in a patient that's hemodynamically unstable, not having to positive pressure ventilate them is really a plus.
And also when you got pulses back, you definitely like. Absolutely, yeah,
Uh-huh.
it was fine.
And then the patient stayed talking. You gave him a little bit of supplemental oxygen. These were the vital signs, kind of following the defibrillations and the antiarrhythmics. I think, did you get him on a little bit of norepi? Yeah. Norepi was started. And then the patient showed up to the ER and you activated a STEMI pre-hospital. I actually don't, may not have. You guys were pretty busy. I think. I mean, this is one that you could certainly activate based on the EKG. Okay.
It was a real quick phone
Adam,
call.
I sent you $50 that you said suspected STEMI.
Did I? Yeah, maybe I did.
Yeah, so and that's a good thing to just kind of in your report. I mean, if you have a patient that's in one of these shockable rhythms and you have an EKG that's concerning for ischemia, even if you don't feel like you have the most, maybe you have a poor quality EKG or is not fully diagnostic, I would have that at least raise that with when you're making your call in just to help get the team ready. Because these are ones that are pretty often going to go to the cath lab.
And you'll get to it, but the glucose wasn't checked. That's another thing that. Did we? Oh, yeah, we did check it. Yeah, we did. It was 370 something.
Yeah, it was higher than expected.
Yeah.
Yeah.
Because so this is just kind of, I don't know, dark humor, but it's kind of funny. This is his first EKG in the ED, so clearly going in and out of this wide complex rhythm. I don't think they actually ended up having to shock it. I think this was brief, but still kind of, if you watch the telemetry for long periods of time, I think you probably see these runs. They were able to get this EKG afterwards, which basically demonstrates what you were seeing in your pre-hospital EKG, these ST segment elevations in 2, 3, and AVF, and probably some depression here in V1,
You can start
too.
to
Yeah. Yep, and AVL, good. So, as you guys said, alert and conversant, they got a few EKGs. This patient was taken for an emergent cath, which I'll show you the report. Also found to be in DKA, so the glucose when he got there was 695. So yeah, a couple things I was going to point out from this metabolic panel, which is not, a lot of this isn't necessarily relevant, but to the pre-hospital setting, but I just think kind of demonstrates what kind of process this gentleman had going on. So he had DKA going on as well, which maybe was a stressor contributing to this. But you see, what do you guys think about the creatinine and the liver enzymes? They're both very high. Why do you think that is? Okay, yeah, that's
Shock liver.
Yeah, exactly. So so this gentleman has clear signs of poor, kind of globally poor perfusion of his organs. So anytime you see that where there's kidney injury, there's liver injury, and the heart is also not perfusing properly, there's just global poor perfusion, and that's why you see this elevation of liver enzymes as well, I think. So this is a pretty significant kind of lesion that affected probably his cardiac output. And that's what they saw on this is the cath report. So he had an LAD lesion, 100% osteal, which basically means like right at the most proximal part of the LAD. So affecting the whole LAD territory, it was 100% included. And he also had 100% right coronary, right mid coronary lesion that was stented. They looked at some old stents of his that were still patent. Yeah.
You asked, they denied it. You asked. Yeah. You did try to check.
Yeah, if I'm interpreting this right, because he had one full post stent. He already had one in his right posterior descending. And he actually went back into ventricular tachycardia during the procedure or after the procedure and was cardioverted. there. So it's a little bit of a wild ride for him. But this gentleman, I thought I had a summary, but he actually did quite well as well, and it was he ended up having still had a lower ejection fraction of like 25% or so afterwards, but was able to be discharged from the hospital a few days later. So all things considered, a good outcome, and I think a lot of good learning points there. So nice work. Questions or comments on that one? Okay, we got one more case. It's a Sultan case, and then we'll take a break. All right, so this is one of Corey's cases. Is Corey on with you guys there?
Yeah, I'm here.
Okay, cool. So this is your 68-year-old female, call for unconscious and unresponsive.
So we got dispatched way up almost to Lake Rossinger for a unconscious unresponsive. What was interesting is in the notes it said patient is breathing, and so it initially came out as a med 1, but the pro QA notes popped up and said that they were breathing 4 times a minute.
Okay.
And so I actually upgraded it to a med X based on that. When we got on scene, I believe it was 831 was the initially on scene. They did 1 round of CPR with no shock and got ROSC. And so started doing a 12 lead, getting a blood pressure. And they had told me that her pupils were pinpoint. We asked the husband about any narcotic use. He was kind of a poor historian. He said nothing like that would happen. But we also noticed some weird kind of superficial abrasions to her wrist that looked very intentional.
Okay.
So I asked the one of the surfer guys to give Narcan that had for some reason got delayed. She was still not breathing, and interestingly enough, she had trismus. So initially I was going to paralyze her. We don't have any paralytics in our box, so I had to send somebody out to the fridge to go grab some. And by that time, she had actually rearrested. We did 1 more round of CPR, gave epi, and again, no shocks, and got ROSC again. It was pretty narrow.
Just to that, I think that point. So sometimes you'll find somebody who's in peri-arrest or arrested, and whatever the process is, which I think we'll jump after this, we'll jump into what we think was going on, but whatever the process is, they may be sedate but not paralyzed, and you may just find that when you go to do your laryngoscopy that the jaw is just very tight for whatever reason. So there are some scenarios where somebody may not need a sedative, but they may need a paralytic, or they may need a much lighter dose of sedative and paralytic. So this is a peri-arrest patient that I would say it's one where we'd use a little bit of maybe a nuanced approach to what we give as opposed to our normal RSI.
I've seen that once in a persistent VFib arrest. She was gone for 27 minutes. She had her jaw could not be open anymore.
Yeah. Oh, I think I remember that. Was that from last year, maybe?
Yeah. Really
Yeah.
cool.
Yeah, so this happens. So using a paralytic, it's worth just doing a bit of an exam before, like as you're getting set up for your intubation, doing the kind of airway exam and seeing how loose the muscles are and what you're going to need in terms of optimizing your intubating conditions. So, but with that in mind too, so tell me you guys are getting started here. What was your kind of thought of what was going on and what was causing the process, or was it just kind of like pretty unclear and trying to sort through things as it came at you?
It was kind of unclear because the husband, I don't know if it was willful or what, but he was not a very good historian. He's like, oh no, nothing like that would happen. She's not on any narcotics. He said that he had just heard her fall in the living room and then came in and she was unconscious and she was just laying on the floor. There didn't appear to be any trauma or anything that was obvious as far as that goes. So she was elderly and she had a history of a brain bleed.
Okay. Yeah.
So yeah, there was just kind of not a good historian and kind of a lot going on. As far as that goes, the aid card told me that her pupils were pinpoint, so I was kind of going down that road a little bit, but not, ruling out the head bleed or anything like that.
Yeah.
So,
And she didn't respond to the Narcan, or?
so it got, I think I had requested they give it before she had rearrested, and so they wound up not giving it until after we got Rosk the second time.
Okay. Yeah.
And then she still wasn't breathing. We waited, I think we were bagging her, but she still wasn't breathing on her own. I think we waited maybe 2 minutes or so, and she still wasn't breathing. And so it seemed like this was a hypoxic arrest to me. And so I was kind of going down there again that road with the Narcan. And since we'd already given 2 milligrams of Narcan and she hadn't responded, I was kind of getting ready to DSI her. So we had put on 2 sources of oxygen. We were bagging her. There were some issues with personnel as far as I had not to throw anybody under the bus or anything, but I had somebody trying to do a weird kind of double CE. And so the MSO 71 was there, luckily, and he kind of corrected that. And we were doing some different things. And so when we went to, we'd push our meds, we were waiting. And during that time frame, she just severely desatted. Okay. And so we just elected to go with an iGel.
Okay. So you got, which I think, yeah, this is your desat there. So when did they desat it and got an iGel in, and it looks like the oxygen sats came up nicely with that. I'm guessing right after, at this point here, is after the iGel got put in.
So we had, we put in the iGel, and I was initially going to, because we had the family was requesting that she go to Evergreen Kirkland. So where I was at was, it was literally same distance to Providence. So I was okay with that, but because of the prolonged transport, I kind of wanted to intubate her. But MSO 71 had said, we should probably, if the iGel's working, he said he had some issues where he got his wrist slapped, I guess, for intubating when the iGel was working. Sure. So we'd elected to leave the iGel in, and I wanted to see how it did with the ventilator. We actually hooked her up to the ventilator with the iGel, and there actually wasn't any issues, really.
Okay. Okay, so
at one point.
Okay, go ahead.
Oh, I was just gonna say, at one point, she did become a little bit hypotensive, and I gave some push dose epi, and it didn't become an issue after that. So.
Okay. So yeah, a little bit of post. I mean, she was hypertensive to start, and then post intubation got some hypotension. So, yeah, I think that this is. I don't think there's going to be a quick and fast rule that works for everything in terms of the iGel. If you have a working iGel, then it's a judgment call about whether the patient would benefit from intubation. I think, everything ended up being just fine with this patient. She went to the ER and she got intubated there, and that was that. But just more of as a discussion of how do you guys all think about this decision about managing an iGel and decision to transition to an endotracheal tube versus just leaving it in for the time being?
I will preface that with, I had everything ready to intubate, and I kind of anticipated there maybe being problems, but because there wasn't problems, I just kind of left it as is.
Yeah. Yeah, being ready to intubate.
Was this patient intubated then extubated?
No, never actually intubated. There was the initial kind of plan to intubate, but there was the issue of the jaw being clenched, and so they, during the arrest, I think, got an iGel in. And so they just went with that. So yeah, so I think if you have a working device and good oxygen saturations, that's important. Things to watch out for would be, if with an iGel you don't have a secured airway, so you're at high risk for aspiration. You need to monitor the not only the oxygen, but the end tidal CO2 and make sure that, you know, you're not kind of having rises in your end tidal from poor ventilation. And you know, if you're gonna be transporting for longer, I think I would kind of lean toward intubation, but definitely having the eye gel. I think with if a patient is getting hypoxic, having something to help ventilate the patient and resuscitate before you do an intubation is absolutely the right way to go. And that's going to give you your best kind of if you are going to move forward with intubation right afterwards, that's going to give you your best conditions for intubating, right? Because you certainly don't want to be trying to intubate somebody who the oxygen saturation is down at 80% to start. That's not, um, you know, that's not going to work. So, so this patient ended up doing just fine in the ED. They stayed intubated. They got extubated a couple days later and went to the medical floor. They did get treated for aspiration pneumonia. And I think you're right. I think this probably was a hypoxic arrest. And so ultimately, this patient admitted to taking 5 20 milligram tablets of oxycodone and some sleeping pills and a suicide attempt. So this was kind of the overall picture fitting of it being kind of an opiate toxidrome. And obviously in retrospect, easier to piece everything together and it's different from what you get in the moment. But you know, you get an unresponsive patient that's breathing 4 times a minute and has pinpoint pupils. I think you get your Narcan as early as you can, but the other part of this is that if a patient is arresting from hypoxia, it's probably too late to say that the Narcan's gonna to turn that around without managing their airway. So a lot of these patients, a lot of opiate patients, we can obviously turn around really quickly with naloxone, but if they're already to the point of respiratory arrest, it's you need to kind of focus on your ABCs before you can kind of reverse the opiates and have it have a significant effect.
This patient did get Narcan again?
She did get Narcan, yeah. Yeah.
Obviously, you're right, prioritizing airway is more important, but Narcan administration and opioid OD arrest does improve outcomes somewhat. But I'm not really, I don't remember any more than that. So,
Yeah. Send it to me. It'd be interesting to read.
Yeah.
Yeah, that'd be a good paper for us to talk about too. Because yeah, it's something that I think there's a little bit back and forth about whether to give Narcan and as part of your resuscitation. And I know there's kind of thoughts one way or the other, but I think this patient I would put in the bucket of saying they were either arrest or peri-arrest from the time that we got there, which is different from your patient that just shows up and is just kind of sleepy from, you know, borderline apneic from taking too much opiate or fentanyl overdose.
obviously. BLS provider would give the Narcan and just chill while they're not
Yeah.
breathing, like, we're not doing that.
Uh-huh. Yeah. Okay. Anything else, Corey? This is a tricky case, but you guys got her where she needed, and it's also hard when the family's not forthcoming, right, about what happened and not giving you help with figuring it out.
Yeah. No, there's nothing else to add to that.
Okay. Sounds good. Well, let's take a quick break here and we'll come back at let's just say 9:45 and we'll finish up.
Yeah, I thought he had some sort of anoxic brain injury.
Anoxic brain injury is a great.
All right, we just lost half our room here to a call, so they're out saving lives and we're still here. Okay, let's we got 9:43. I guess we got another minute or so. We'll get started. Okay, let's get started. So we'll start off the second half here with the RSI trial, which is the full title is Ketamine or Etomidate for tracheally intubated and critically ill adults. Sorry, I just messed that up. This is the not so exciting front page. But anyway, so I think this is probably the most interesting trial that's come out that I've seen this, at least this year, as it pertains to you guys and the work that you do. From an EMS perspective, I just had a few questions here. So I was curious, so this is my question to you all before we talk about the paper. And this will have to mostly land on people online because our room here is pretty empty. But Francis, feel free to jump in. How do you guys think about ketamine and etomidate as your induction agents for intubating? When do you reach for one or the other? Is there one that you think is superior to the other? How do you think about that?
Personally, I reach for ketamine every time. And I don't necessarily have a good reason. I'm not a fan of etomidate, I guess.
Okay. Ketamine every time?
Pretty much.
Okay.
It depends on the patient.
Okay.
For me, what I think is the primary cause for the reason why we're doing it, right? Respiratory patients, ketamine is shown to have some, beta agonistic effects that can potentially help open the airways. But again, you got to think about stress on the heart for the same thing. So cardiac patients. I personally have never had a negative effect with etomidate. I've never dumped someone's blood pressure with it. I have seen an extrapyramidal reaction with ketamine, but it was probably because it was pushed too fast. So,
Okay. Those are all good points.
Yeah, I'm kind of in the opposite camp. I've had 2 or 3 patients that were kind of in the gray area, and etomidate dumped them, and one of them coded on me. So that's probably why I don't reach for it very often anymore.
Yeah, which is a fair. I mean, I think like that's a kind of why I wanted to bring this up. Is like a lot of what our practice ends up being is anecdotal in our clinical experience, and I think there's value in that because as you gain experience over your career, you base your decisions on what you've seen, and but it's helpful to have kind of big studies like this to help check our experience with what the data shows in these large trials. So cool. I think that's really helpful background to this study and just something to think about as we move forward. Why we choose one or the other. So we talk about respiratory cases for ketamine. What's another one in the kind of with the new changes to the protocols that we've been talking about for indications for ketamine? Yeah, seizure. So it's a natural kind of progression in our status patients to move to ketamine after a couple doses of large doses of benzodiazepines to move on to ketamine. And then another question, like I said, for the other one is, does this apply to our practice? And that's just something to keep in mind because this is a little bit different in that it's not a pre-hospital study. So this question, the question of this study is ketamine a superior agent compared to etomidate for RSI in critically ill adults? And even just from this little discussion, there's been a big move towards ketamine over the last few years. A lot of people are using it for pretty much any indication of RSI, and for good reason. There's a lot of plus sides to ketamine, and we'll get into those. And I think that's moved more and more people to just say this is my RSI drug of choice. There have been some observational studies that apparently have shown some increased risk of death with etomidate. So small studies, not randomized controlled trials, but some association with death with using etomidate to induce anesthesia. And then this is something I'm sure everybody's aware of, but maybe worth reminding and just something to think about is that one of the really well documented kind of side effects, I guess I'll say, of etomidate is it does cause adrenal cortisol suppression. So for up to 72 hours after you give etomidate, it'll suppress secretion of cortisol. And especially in septic patients, this can cause an increased risk of organ dysfunction. And actually, they pulled it from the market in multiple countries because of this. So like completely unavailable. I know Australia is one of the countries that doesn't carry, it's basically kind of black labeled for that reason. So another kind of reason why this study brings value is, I would say, kind of historically, etomidate was a drug that a lot of people trained with, let's say 20, 25 years ago. Ketamine has become, in the modern times, more popular, and the question is, how do these stack up in a head-to-head trial? Ketamine acts on different receptors. So etomidate acts on GABA receptors. Ketamine acts on MDMA receptors and does not affect cortisol production at all. It can cause an increase in catecholamines, which is thought to maintain post-intubation hemodynamic instability. Some smaller studies they listed that some smaller studies had shown some hypotension with ketamine. So I guess this is just to say there's a little bit of a mixed bag in terms of what can happen. And we'll get into that hypotension with ketamine discussion a little bit more in just a second. Okay, so what was this study? So this was an unblinded study, which meant that the people giving the drug knew which drug they were giving, but they were basically, when they decided to intubate, they were either randomized to etomidate or ketamine. This included intubations that happened in the emergency department and intubations in the ICU. So again, this is not a pre-hospital study, but I think this patient population is pretty similar in a lot of ways to the ones that we do intubate pre-hospital. The clinicians were able to choose their ketamine dose anywhere from 1 mg to kg to 2 mg per kg. And they also were able to choose their etomidate dose. And that's a little bit notable and something to think about is, so with etomidate, typically, I would say more commonly, we don't dose adjust that one as much as we do for ketamine. We typically just give the 0.3 mg per kg. And there's not a lot of data to say what happens if you give etomidate in kind of like a stepwise fashion like we do with ketamine. But everything else about the patient care was kind of clinician discretion. So whether they gave sucks or rock for paralytic, whether they gave vasopressors around the time of intubation, whether they gave fluids, whether they gave steroids, all those things were kind of normal best practice care. The outcomes they looked at, the primary outcome that they care about is a good one. When you're looking at studies, these are the ones that this is kind of an important thing to cue in on, is is the outcome something that matters for patients? And I would say death is one that probably matters to patients. And the outcome is death at any cause at 28 days. And then the other ones that they dig into was there cardiovascular collapse right after intubation, which was defined as systolic blood pressure less than 65 millimeters mercury. They have to increase the vasopressor or start a new vasopressor, or did the patient go into cardiac arrest? So those are ones that we care about a lot, right? When we intubate, we're not thinking about what's going to happen in 28 days so much. We're thinking about what's going to happen immediately post-intubation. Not that we don't care what happens in 28 days, but we need to kind of manage the short term as well. So these secondary outcomes do matter to us. Bear with me here, but I just was going to show you a few of the tables from the study to kind of show you how this study was broken down. So this was a really well set up and randomized trial. Table 1 for any big study like this, a randomized controlled trial, is worth looking at to say, what was this patient population and were they kind of equivalent to each other? And so you just look through both these major groups here, and you notice that both of these, they're very similar. Medium age is the same. They have, the racial breakdown is the same, and then you go into their chronic conditions. It's a very sick population with a lot of comorbidities, cirrhosis, heart failure, coronary artery disease. There's a lot of patients that were in sepsis, which is kind of the population that we care about the most, is at least in terms of intubating medications, is, there are patients that we intubate where the induction agent may not matter that much because they'll be hemodynamically just fine no matter what we give them. But the sepsis patients or patients in septic shock are the ones where we are really probably highest risk in terms of doing harm if we choose the wrong induction agent. So it's important to note that this is a really sick population here, and they're pretty evenly split between the two. And the reason that's important is to say that any difference between the two, in the outcomes is not from a difference in the patients that were treated, it's actually in the drug itself. Okay. And then getting into the kind of characteristics of the intubation itself. This is kind of funny. So in the ketamine group, this is showing how many patients were given ketamine in the ketamine group, and that's almost all, but somehow some of those patients still got etomidate. Don't ask me to explain that. I just thought it was funny, but that happened. Probably some just issues with logistics and giving the medications. Again, it shows that there wasn't a huge difference in whether the ketamine or etomidate patients got ROC or SUX. And then you go down into like how they were pre-oxygenated, whether they used a bougie or a stylet. All these things are very similar. So in other words, the intubation conditions weren't changed other than given the only difference really between these two groups is the choice of induction agent. Do you guys know how to interpret these the difference tab here and the 95% confidence intervals? Like what to make of these numbers in parentheses here? I promise I won't go too far into statistics, but I just bring it up because you'll see this in a lot of studies, and it's worth kind of knowing what those numbers mean. Not quite. So these basically the 95% confidence interval, if it goes from negative, crosses 0, basically, there's no significant difference between the two. So the only one where you'd expect to see that would be there's a significant difference in the ketamine and etomidate because that was the actual difference between the two groups. So you see here the number is 98.4 to 99.6. And the difference here is negative 99.6 to negative 98.5. So these don't cross 0. There's a significant difference between the groups in these two categories. Every other single one, it goes from a negative number to a positive number, which just tells you that there's no difference between the groups in any of these measures. Does that make sense? Okay. No. Yeah. Okay. This is what we care about. This is the days since randomization and the mortality rate. and they're the same. So basically, the primary outcome shows that at 28 days, there was no significant difference between the ketamine group and the etomidate group in patient mortality. This is a much more like played out version of the results. Again, no difference here. It goes from -4.5 to 2.9. Interestingly, there were some differences in the secondary outcomes, and the differences favored etomidate. So in etomidate, there was fewer episodes of low systolic blood pressure, fewer instances here where the patient needed more vasopressors, and fewer instances of cardiac arrest, which actually this is not clinically significant. But basically, less hypotension and less vasopressor need in the etomidate groups compared to ketamine. And this kind of goes, this is basically looking at the different patient factors that could have gotten into it, comparing etomidate and ketamine. So kind of what this figure is asking is there any situation where you might choose one or the other based on patient condition? And you could actually look at just this plot here alone and know right away that there's no difference between the two. So this is called a forest plot. And basically, anytime where the line crosses the middle, it means that there's no significant difference between the two groups in terms of intervention. You may see like a trend one way or the other, but anytime it crosses the midline, it means that there's no clinical significance between the two. So it doesn't matter if the patient had vasopressor use beforehand or adrenal insufficiency or a cardiac condition, whether they got ketamine or etomidate, they didn't have any change in their mortality. Okay, so this is the conclusion of discussion. So use of ketamine did not result in a lower mortality rate than etomidate when used for RSI in critically ill adults. Is that surprising to you guys?
I don't know if it's surprising, but I definitely thought there would be a significant indication one way or the other that there was a significant difference between the two.
Yeah, that's kind of how I responded too. I guess when I thought about it, I don't really think of any of the medications we use for induction and other than propofol as being capable of causing high mortality rates when used in the wrong person. So between these two drugs, I'm not surprised, but I did think that the results of the secondary results were pretty interesting. So ketamine causing more hypotension, vasopressor use, and actually episodes of ventricular tachycardia, which somebody pointed out they don't like to use ketamine in cardiac patients. That's, potentially the risk for VTAC and the catecholamine release would be a reason why. And that was especially true in patients with sepsis, which is really the patient population that we do care about. So, and this is the largest study we have comparing these drugs directly to each other. So a little bit of a discussion of what do we do with this data. So what do you guys think about this? How does it apply to you? Is it generalizable?
I think it just brings up a point that any medication that you put into a body has positive and negative consequences, and we just need to think, give a little extra thought while we're choosing our medications. I think it doesn't necessarily need to completely drive. Like Chris said, he's way more comfortable with ketamine. Like, keep crushing it. You know what I mean? But just something to also always keep on your mind.
Yeah, I really approve of that attitude. Yeah, I mean, Vernon killed it with Yell and booze for 15 and if that's working for you, why change it?
Yeah.
I'm also wondering if any of them, because it's really important to push ketamine slowly, and I know that wasn't required. It would almost be impossible to get around to notating in chaotic crashing sepsis innovation.
Yeah, they don't get at that. And I agree. I think that there's for those of you who love ketamine, I think, and I've heard actually this argument that ketamine can still very reasonably be given safely to all these patients, but I think the thing for me that this paper brings up is that there's a little bit of nuance, and especially in septic patients. And I think Chief Durrells will probably jump on to expand on this more, but I would think of these as being good sick septic patients are great patients to do a delayed sequence intubation on if you're going to use ketamine. So you give some ketamine and you get them to a place where they're comfortably dissociated so that you can kind of appropriately pre-oxygenate them and resuscitate them, and then you move forward with your intubation, which is not something that they explore in this trial. These are all rapid sequence intubations. And I think if you're going to use ketamine, that is still going to be a very safe approach and pathway. But it does demonstrate that if, as like Francis said, if you just rapidly push ketamine in a paralytic, it's maybe not totally shocking that you're going to get some adverse outcomes in these sick septic patients. So I'm not sure if definitely. Yeah, which kind of gets to the next question I think is worth just pondering for a moment. So why do you guys think that there were higher rates of instability with ketamine after intubation? So these were so there was higher rates of blood hemodynamic instability, cardiac arrest, and ventricular tachycardia with ketamine post-intubation. This is not discussed in the paper, but it's something that's been discussed in the community a bit afterwards, and I think is probably a pretty good explanation and one worth thinking about.
Is it increased metabolic demand? You're burning through the meds faster along with that catecholamine release. The body's not compensating as well.
That's a good thought. It's actually the catecholamine release with ketamine is a real thing, but probably in septic patient, those people are probably already totally stressed and sending out all the catecholamines they can. And so they're already kind of catecholamine depleted is how I would think about them. And so you don't actually get that kind of response, which is maybe one of the things that, the potential benefits of ketamine in the first place. And that's maybe why you don't see the benefit with sepsis is they've already kind of spent those catecholamines trying to maintain their blood pressure for however many days that they're sitting on their couch with their UTI. But ketamine has pretty significant analgesic properties in addition to sedative properties, right? We use it as a pain control medication as well. Etomidate does not have that. It's just a sedative medication. So there is one thought is that when you give ketamine, you're not only sedating the person, but you're also controlling their pain. And that may actually be something that, lowers their blood pressure because it may be a little bit of a pain response that may be actually keeping their hemodynamics up in the peri-intubation stage. Whereas with etomidate, you're literally just giving a sedative with no kind of pain control afterwards. And certainly there is importance of giving appropriate post-intubation sedation once a patient is hemodynamically stable. But my guess for the mechanism for this is that you're getting the pain control as well as the sedative with ketamine, and that's why you see a little bit of this drop. And I think that's just important to keep in mind. So that any sedative you give and any intubation, it's very possible you could cause hypotension, but especially in a sedative that has pain control properties too, because you lose that kind of pain response that you get from the intubation. Does that make sense?
Yeah, that does.
Yeah. So, and this is not to like I said, I think ketamine's great, and there's a lot of reasons, and there are very specific intubation indications where I think it's probably the only medication you should use. But to just to bring some nuance into your practice, I think there's a lot of value to that. What else do I have here? So it's important to note that this trial excluded trauma patients. Trauma, is different. They're not septic patients. And so we treat them differently for intubation. So I would say my full disclosure is that I use etomidate for most of my medical intubations. I've had good experience with it. What I would, to loop back on the kind of concept of the cortisol suppression with etomidate in septic patients. One of the other things that has progressed in critical care medicine over the last 10 years is that in patients who have refractory hypotension, as part of their bundle for treating them with vasopressors and things like that, we're giving stress dose steroids to a lot of these patients too. So that drop in cortisol can be addressed in the critical care setting by just supporting them with hydrocortisone over the next couple of days. And it seems, and one of the other things that we could learn from this study is that the septic patients did okay, even though they got etomidate. So that's another kind of, I think, valuable piece of information to just add to our knowledge, is that giving etomidate to septic patients didn't kill them. Yeah. Just one's all, yeah. Yeah, because we only ever give one in the ED too. Good. Other thoughts on that?
Hey, Dr. Fortier, can you hear me?
Yeah.
It's John. Hey, one thought I had that also kind of supports the ketamine camp a little bit is it has a longer duration of action. So if you have a complicated intubation or something and have to do multiple attempts, etomidate will only give you like 5 minutes or so of sedation time.
Yeah, I guess I think there's some truth to that, and that I mean, the idea with RSI is that you're kind of it's the same with giving your paralytic. You're trying to set your best conditions for your first attempt, and so I think for your average intubation, probably not preparing for a super long one. But I agree that in the pre-hospital setting, there's maybe a little bit of a difference from this study in that you guys having a medication that you give once and is on board for a longer period of time is a clear benefit to you, right? Because you're dealing with a whole lot of things. You don't have all the support, and it's pretty easy to give ketamine as your one drug, as a sedative and a pain medication, and to just be able to give it for the induction and maybe given a second dose on your way to the hospital is there's just some use benefit there. So I think that is a real factor for you guys, and I think that's a place where probably my practice is a little bit different in that oftentimes after I intubate, I'm reaching for my propofol and fentanyl drips immediately post intubation, and it's not hard for me to just start them on a vasopressor if I need to. But for you, I think simplicity is in medication management there's a huge benefit to that, just because you can only do so much in the short period of time that you have. It did not change mortality. Yeah. 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 Okay. Well, good. Thanks for discussing it. I think it's interesting. Chief Duros has these papers she'll send out to you, and I send it out to the Granite paramedics. So take a look at them for yourself, and feel free to reach out if you have any other questions about it. I'm not telling you to do anything with your practice other than to have some nuance and consideration for different scenarios and which one may be better than the other. And so I think that this trial is helpful for digging into that a little bit more. All right. So we got a Sultan case here. This is Sean's case. Sean, on with you guys? Or how about, okay. Okay. Anybody else there on this call? This is a 43-year-old, shortness of breath.
I got called to that afterwards. So it was kind of late in the game.
Oh, okay. This is Corey.
Yeah.
Okay. Yeah. Well, do you mind just, Corey, filling us in on what you guys got started on for this case and what happened?
Yeah, so initially came out as a 43-year-old with shortness of breath, was called in by, I believe, the 16-year-old daughter of the mom. The son and daughter were home, both in their teens. Mom had a history of seasonal allergies that were bad enough where she would take an inhaler, and she had been using it excessively, thinking that was probably the problem. But when they got on scene, she said that she had just recently had a laparoscopic hamstring surgery from a previous hamstring injury. I got dispatched as the second medic unit and was told to just, set up for intubation. So when the patient came to me, she was, clearly in respiratory distress and borderline respiratory failure. So we elected to RSI her. It was interesting. I don't know if it was coincidental, but her vitals and everything seemed to be fine. We elected to go with ketamine and rock, and her blood pressure dropped significantly, and then she actually Brady down as well into the 30s. So that was another case where we put an iGel in. We gave push dose epi and then started an epi drip, as well as started to pace her. So we did get her heart rate back up and her blood pressure back up. The iGel didn't seem to really be working. So we elected to intubate her. And then transported. During transport, she coded. We had already applied the Lucas prior to transport. So we utilized the Lucas. Once we got to Prov, they got Ross 2 or 3 times, I believe. I didn't know the whole end of the story, but
Yeah.
I see the 12 lady.
Yeah. So, okay. So thanks, Corey. So perfect. So it's a super sick patient. So, kind of getting her set up. You guys got her on, it looks like, non-rebreather or high flow nasal cannula and was still not oxygenating. Is that right?
correct. When I saw her, she was on a non-rebreather.
Non-rebreather. Okay. This is the initial 12 lead. So what are you guys' thoughts on the 12 lead here? Let's just say a lot. So what's our highest concern for this patient? PE. Yeah. She just had a hamstring surgery. 43,
Oh, okay.
46, young. So most common EKG finding in PE is sinus tach, but of course, the classic pattern is S1, Q3, T3. Maybe,
That Q wave is quite pathologic.
yeah, I wouldn't call those pathologic Q waves either, but definitely has a T wave inversion in lead 3. So if nothing else, and she also has the rightward axis too. So all things that kind of should cue us in on possible pulmonary embolism. And so this is the rhythm that we got I think, we talked about after intubation, she bradyed down. So who wants to describe this CKG? This is a funky one. So AV dissociation, okay. Okay. Wide complex.
ST elevation.
Is it wide complex? It's a little hard because the J point elevation there, I think, is what is kind of slurring into the QRS. So I would say for sure the right axis deviation is more extreme at this point. There's a certain morphology change between the two.
Does this patient have a pulse at this point?
Yeah, Corey, so I'm not sure if you remember like the timeline of these, but so you're not pacing the patient at this point. Is this a perfusing? I assume that she has a pulse at this point because
Yeah.
you're getting EKG, but
Correct. She did have a pulse at this point.
and then did she respond to pacing? Was were you able to pace her?
Yeah, we got capture on her, and like I said, she at one point, at least I believe her blood pressure improved.
Okay. So she really bradyed down. I mean, this we can kind of dive into this more. It's what it was that it caused the kind of bradycardia and the decompensation. But so yeah, so the patient coded in the ED for another hour. They put an A line in, and basically she essentially was peri-arrest or PEA arrest the entire time. They actually gave empiric thrombolytics, TNK, I think maybe 2 doses, just because they also felt like PE was the most likely diagnosis here. They consulted cardiac surgery to see if she would be an ECMO candidate, but due to her kind of prolonged downtime, they didn't think she was a good ECMO candidate, and she ended up expiring in the ED. So yeah, I think this is a really sick patient and obviously a tough one. This is somebody who is going to be a really high risk intubation, but I think, we kind of, it sounds like we were at a point where all of our options for managing this kind of pre-intubation resuscitations had been exhausted, but really your options are is, if you're saying empirically, we think this is a PE, you can give them as much oxygen as possible via non-rebreather or high flow nasal cannula. But if you're not getting their oxygen saturations up, at some point you need to move forward with positive pressure ventilation. But of course, what's the big risk of positive pressure ventilation in this case? Yeah. So as soon as you intubate them, then you're kind of running into a whole new set of issues. You're going to be able to oxygenate, but their hemodynamics are going to be really compromised, which is, I think, what we saw. So you're in a place where this patient is you're in a really tough place. So I don't think there's just a big change or commentary other than to say that these are really sick patients that we have to do our best to resuscitate, but this is something that can happen if they're that far down the spiral already, which we'll kind of talk about a little bit more. Do you remember how many days post-op she was, Corey?
I don't recall, no.
Okay. Okay.
Is this patient generally overall, the general overall health good, or is this a patient that, you know, smoked a bunch of cigarettes, was obese, possible polysubstance abuser, or is this a generally healthy person? Wow.
So that's more suggestive of a cause of immobility post-surgery rather than the surgery itself, just that she didn't get up and move around.
Oh, boy. Yeah.
Yeah. Okay, let me, so I thought I'd use this as one thing that we can think about in patients like this, if we're trying to get a little bit more diagnostic information as we move forward with ultrasound, is thinking about a cardiac ultrasound. And so I was going to do a quick review and a couple kind of side notes. So these are basic 4 cardiac ultrasound views. We've already been through this once. If you've been through POCUS training, you probably have seen some of this. Probably the most common one that we use is the parasternal long axis view, which is kind of just the left of the parasternal border. Indicator probe is toward the right shoulder. Getting this view where you get the right ventricle on top, left ventricle on bottom, and then you kind of look at the aortic outflow tract and the left atrium here. If you turn your probe 90 degrees toward the left shoulder, then you'll get the parasternal short, which is just kind of like a cross-sectional view through the heart. Other views, the subxiphoid 4-chamber view is probably your most useful one for cardiac arrest patients or a patient where you already have the Lucas in place. It gives you a 4-chamber view of the heart and a good comparison to the right and left ventricles, which we'll talk about in a second. And same with the apical 4-chamber, just kind of inferior to the left nipple. And you can get a good 4-chamber view of the heart with that as well. There's another look at the parasternal long. So just thinking about a pulmonary embolism, let's say we get a parasternal long view of the heart. What changes do you think you might see in the cardiac ultrasound if you had a PE patient? Okay, good. Something might happen to the right ventricle. That's a good start. Anybody else? Why do you say that, Francis?
It's good.
Okay. Yeah, so if there's a pulmonary embolism, there is a blood clot in the pulmonary artery, which significantly increases the pressure of the pulmonary artery, and that pressure pushes back into the right ventricle, which can cause right ventricular dilation. And the way we see that on ultrasound is basically comparing the size of the right ventricle to the left ventricle. So in normal hearts, this is a normal heart ultrasound, the left ventricle is much bigger than the right. As we get increased in the pulmonary pressure and if there's a PE, then we see the size of that right ventricle start to balloon out. And we may also see that this septum here start to push towards the left ventricle a little bit, which I'll show you in a second. It's a great question. I can't think of an easy way off the top of my head. I'm not a POCUS master. That'd be a good question for Dr. Gardner or Dr. Johnson. Yeah. You're going to be getting into a little bit more of the kind of advanced echo stuff with that. So let's take a look at this video. So this is an ultrasound. I'll just say right off the bat, the video on the left is a normal heart, 4-chamber view. This is the ultrasound on the right is a heart with a pulmonary embolism. So what you see here is the left ventricle. Can you guys see my cursor? Okay, left ventricle. Can you see my cursor on the screen, or is that hidden?
You can see it.
Okay, so this is the left ventricle here, which means this is the left atrium. This is the right ventricle and right atrium. And this is a normal heart on the left. So let's play the video. So you can see size, much bigger left ventricle than the right. the septum is fairly flat, not moving. And what you see here in a PE is this really ballooned out right ventricle, and you see the septum, which is actually in diastole, the septum is bowing toward the left ventricle, which indicates that there's volume overload. And you also see the right atrium kind of backed up with fluid too. So this is a finding that if you just pulled out your POCUS and you saw this could be really helpful diagnostic information, right? Especially if you're saying this patient, maybe we need to intubate him, maybe we don't. I mean, that's different from this case, but if you see this big dilated right ventricle and you're like, wow, I'm going to do everything I can to try to stave off intubation and get this patient to the ER, this ultrasound finding would be a good one to pick up. And then this is another look, just a different view of the heart. So this is the peristernal short view. And so basically here you get this is a normal heart, left ventricle, right ventricle, and you see just a nice cross view of the heart. And this is what it looks like in a pulmonary embolism. So you can actually see right here, the heart, this is a tachycardia, the heart's just beating really fast. But this right ventricle is just super dilated and even bigger than the left ventricle is. So, and you see that septum kind of paradoxically moving toward the left ventricle just because this pressure on the right ventricle is so high. Questions about that at all? So pretty basic, but these are, I just wanted to kind of bring to mind some situations in which your point of care ultrasound is going to be helpful in your clinical decision making and times when you might reach for it. So yeah, that's that for that case. I would say that the takeaways are, this is like a suspected PE patient. You're going to resuscitate until you get to the end of your treatment plans, whether that's with high flow oxygen, vasopressors. I actually had a few slides I'm realizing now that I'm missing on the kind of right ventricular death spiral, but maybe we'll talk about that next time. But if you have to intubate these patients, just know that this is one of those kind of those patients that can get really unstable post intubation, and so it's a tough case, and but good one to kind of think about all the different approaches we can take for management. So, all right, that's it. We have a couple more that we didn't get to because we did a lot of chatting today. So thank you guys for chiming in. I'll save these cases for next time. Have a great month, and we'll see you in August. Thank you.
Thank you.
Thanks, guys.